we're going to cover the abdominal exam for the checkoff at this point. We're going to start with inspection. And so you're going to expose the whole abdominal region, have the patient supine, pillow behind the head, and you're going to look just at the skin texture for any lesions. You're going to look for pulsations, any evidence of peristalsis. So you'll want to get down so to be able to tangentially look at this. Some of the early signs of small bowel obstruction might be that you may see some peristaltic waves. Those are normally not seen on exam. You're going to look at the contour of the abdomen. Is it scaphoid, flat, distended, round? And so you're going to describe the shape of it. You're going to look for any lesions, venous patterns that may show up, and any distension. And then you're going to move on to auscultation. And you're going to start with auscultation of the 4 quadrants. So we're going to start here in the right upper quadrant, and we're going to listen for up to 30 seconds to hear bowel sounds there, very slowly, take our time methodically, and then we're going to go clockwise to the left upper quadrant, listen very closely for bowel sounds, left lower quadrant, and then right lower quadrant. Okay, and remember we would listen for a full 5 minutes to make sure that there are bowel sounds present. You're going to listen under the liver area and have them take a deep breath in and out for friction rubs. So over the liver area, over the spleen area, in and out, listening for friction rubs. Okay. Now you're going to listen for bruits. Your aortic artery is just off to the left of center here. You're going to listen very closely there. And then in the costal angle, we're going to listen for renal artery bruits on either side here and here. And then iliac artery, generally in this area. You can also palpate that area to feel that pulse, and then place your bell over that and listen. Then we would come down and we would listen to the femoral region for bruits there. All right, and then we're going to listen around the epigastric region. The epigastric region for venous hums, and the periumbilical region, again, for any venous hums. We would listen in all those areas right there. Now we're going to move on to percussion. So in percussion, we're basically going to be listening for the tone. Over areas of solid organs, you would hear dullness, as in over the liver area. So we're going to percuss here, and you just place your hand firmly on the abdomen, and then you're going to strike it with your other hand. You can use multiple fingers or single finger, but we're going to listen real close to the sound that's dull from being over the liver. And then we move over the abdominal region and compare for a little more tympany there. You see here that has a little bit more of a hollow sound to it. It's a very subtle difference. Okay, and so you're going to just kind of generalize and percuss around the whole area, over the bladder area for dullness. All the quadrants, and then we're going to percuss for liver size. So we're going to start in the mid-clavicular line, the right lower quadrant here, well below where the liver margin should be. And we're going to percuss and work our way up until we hear the tone start to drop off a little bit. Right there, so we know the liver margin begins here. And then you're going to start from above here into the lung tissue area and percuss. And you can hear that tone start to drop off a little bit. So basically the liver margin is going to be right here. And that's how you determine where the margins are from percussion. Then you're going to do the same thing with the spleen over here. I'm going to start at the base of the mid-axillary line at the rib cage. soon as you get up above that spleen, you'll hear it's a little bit more tympanic because you're over lung tissue area here. So basically your spleen is right in through this area right here. Okay, and then we are going to start with palpation, and we're just going to generally start light palpation over the areas, feeling for that muscle tension in cases of appendicitis, when there's infection in the abdomen, that muscle wall will get tender. If they have a strong abdominal wall just from an athletic build, you could put a pillow up underneath the knees and flex the knees up a little bit and the hips, and and you would just come back and refill it again. And so again, light palpation is about less than 1 centimeter. And then we're gonna move to deeper palpation. We're gonna kind of press in here and feel for that liver margin and just have them just relax as much as you can, feeling for that edge of that liver right up underneath the rib cage here. Okay, and then palpating for the spleen, we're going to reach up under here and support that rib cage and just see if we can feel the edge of the spleen up under here in the left upper quadrant. Okay, and then the kidneys, we're going to come right in this costal angle and deeply palpate, see if you can feel the pole of the kidney there. And then on the right side, same thing here. We're just supporting behind that rib cage, pulling that retroperitoneal area up. And then you're going to deeply palpate and feel for any masses or tenderness. Remember, on your female patients, in midline just above the bladder, you're going to feel the uterus. And we're just feeling for any tenderness or rebound tenderness. So Rosvig's sign is going to be over here. So if they have tenderness in that right lower quadrant, you have signs of peritonitis. If we push down here and release, if that causes pain over here, that's positive Rosvig's sign. So just generalized rebound tenderness, you could push down, and then when you release, if that causes discomfort there. Iliopsoas muscle test. So you're going to push up with your thigh, and I'm pushing down here, and if that increases the pain, that's iliopsoas muscles positive for peritonitis. And then the obturator sign, I'm going to take, flexing up to 90 degrees here, and then internally and externally rotate that hip, and that'll create irritation in that right lower quadrant as well. And then ballottement, we're going to do to feel for masses. So basically, if we're suspicious that there's a mass here, we're going to just push straight down one-handed, and then that mass is going to kind of come up and bounce against that, and you'll feel that. And if you really want to estimate that size of that mass, you can kind of catch both sides, and what you're trying to do is catch it between both your hands and feel the size of that mass. One of the things we can do if there's ascites or fluid in the abdomen is percuss for that. And so we can work our way from the midline. And as we would go over here, when we get a change from tympany to dullness, we know that that line of fluid may be from here, because fluid is going to be gravity dependent. And so however far down you percuss, you would mark that, and then roll over that way. And then we would let him sit here for a minute, and the fluid would drain down that way. And so we would percuss again down here until we felt a change from more tympany to more dullness where the fluid is, and we would know that that fluid had, being gravity dependent, settled down that way. Okay, turn back over on your side. And in an obese patient, if you're really having trouble finding the mid-liver margin, you can use the scratch test, in which you're going to be listening with your stethoscope, and then you're going to scratch with your finger and gradually get closer and closer. And when you get to that liver margin, it's going to amplify the sound a little bit. You'll hear that louder as you get to the liver margin, because it's going to conduct that sound a little bit better. All right, And that is the abdominal exam. All right, the final portion for the abdominal exam is to percuss the kidneys for tenderness. So we're gonna basically look at the costovertebral angle, and where the bottom of the rib cage comes up and attaches, that's gonna get you to T12, and the kidneys sit on either side in the retroperitoneal space. So we can just do direct percussion, and we're gonna just hit very lightly over there to see if there's any tenderness. Indirect percussion would be like this, just cover both sides with your hand and hit there. And you're just really feeling that CVA area for tenderness there.